Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network at the Lineberger Comprehensive Cancer Center. Thank you so much for being here today, August 28th, 2019, for our Medical and Surgical Oncology lecture. Just a few preliminaries to go through and then we'll meet our guests and get started. Let's see, if you're having any technical difficulties, please give us a call, 919-445-1000. You may also email us at unccn@unc.edu. Let us know if there's a problem. We have people standing by who can help you with that. And this is also being recorded. So if something just doesn't go right today, we do have this recorded in our learning portal, and you can actually receive credit after watching that, as with all of our lectures. All right, we'll be using Poll Everywhere today. That allows you to interact with our presenters and to ask questions at the end. Two ways you can join us using Poll Everywhere. The easiest way, I think, is just go to pollev, pollev.com/UNCCN. So pollev.com/UNCCN. You'll see the questions as we present them on the screen. You can answer, and then you can type in your own questions at the end, any web browser, including on a smartphone. If you don't want to do that and would rather text us, just go ahead and in the text message field, in the to field, type in 22333 in the message field where your actual message is. Type in UNCCN. Send that to us. You'll get a message saying join. And then you can select the letter that corresponds with the answer that you feel is right to the question and send that to us. We really appreciate everyone who participates in these Poll Everywhere polls. It's all anonymous, and it's a great way to get a dialogue going between you and our presenters. All right. So let me go ahead and zoom out so we've got everybody here. And we have two guests today. So thank you so much, Dr. Weiss and Dr. Rose, for being here. We're really glad to have both of you. Dr. Weiss, I've got a little bit about you, focused on treating patients with lung cancer and head and neck cancers. And you let me know if I'm off base in any way. So far, so good?
Pleasure to be here, and thanks for picking a picture where I still had hair.
Oh, you bet. Yeah, we try
Dark
to do
hair
that. Yeah. I have not spared myself in that same way, so but maybe I should. Research concentrates on clinical trials in lung cancer and head and neck cancer. Section Chief of Thoracic and Head and Neck Oncology and Research, Pod Leader for Thoracic Oncology. Associate Director of Finance for the Clinical Protocol Office, Vice President of CancerGrace.org, and an advocate and board member of the Lung Cancer Initiative of North Carolina. Sounds like enough to keep you busy. Great. And what's one thing we should know about you that wasn't on that list? Maybe something outside of your professional.
I have three wonderful daughters, one of whom is in daycare with our other guest daughter.
Oh, great. Great. Very good. All right. Dr. Rose, Assistant Professor in the UNC Department of Medicine, Division of Hematology Oncology, and clinical and translational researcher. Clinical interests in the treatment of patients with genitourinary cancers, including bladder, kidney, prostate, and testicular cancers. Focus on the development of novel therapies and combination therapies for patients with urologic malignancies, including the design and implementation of clinical trials, and studies the molecular alterations that contribute to the development of genitourinary cancers. Is that about right?
That's about right, thanks.
Good deal. And what about for you? What's one other thing we should
Well,
know?
I mean, I also have three daughters.
Wow.
So between us,
It's a requirement.
we're going to be in trouble in about 10 years.
Okay.
I'm already in trouble.
So maybe we can just change the topic and talk about parenting three kids today instead.
Well, it's supposed to be something we know something about. We have some expertise to offer.
Okay.
But a Poll Everywhere, if you want to tell us how to handle this, we'd welcome it.
Okay, good deal. So I mentioned we're going to use Poll Everywhere. This question hopefully is a softball, although there may be a few complexities to it. Which of the following is a type of genitourinary cancer? A, squamous cell carcinoma, B, adenocarcinoma, C, prostate cancer, or D, small cell lung cancer? So go ahead and put in an A, B, C, or D, and then we'll take a look at that and see what your responses are. While you're putting those in, let me go over the disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. Thomas Shea consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. Dr. James Coghill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Dr. Weiss receives consulting fees from Celgene and has no other relevant financial relationships with commercial interests. Dr. Rose has no financial relationships. All righty, let's see how they're doing on the poll.
So I would say generally correct. Clearly, prostate cancer is a type of GU cancer, although it's also an adenocarcinoma, so the people that answered B are not incorrect either.
Not incorrect.
And we can see actually both squamous cell and small cell cancers in the GU tract too.
So no wrong answer here. Maybe the softball was C, but any of these would actually technically be correct. Okay, so we unintentionally added some subtleties to this question. And without further ado, Best of ASCO 2019, Lung and Genitourinary Cancers. And Dr. Rose, let me pass the controls off to you first. There's that mouse for cursor if you need that.
Great, thank you very much. So we're going to start with the GU portion of the session today. And I'm going to try and cover kind of a range of the cancers in this talk. So this is just my research funding, which is not relevant, I think, to this talk. So this is my agenda today. First going over some kidney, then bladder, then prostate cancer, and really just the recent updates in the last 6 months. And in all of these cancers, the field is moving so fast that there's actually a lot to talk about. I think the biggest news was in kidney cancer with some of the first-line combination treatments. So I'm going to start off with that. We're going to talk about some of the adjuvant data we saw at ASCO this year. Talk about a new agent in bladder cancer. That'll be after platinum and after checkpoint inhibitors that we have hopefully the option to use soon. And then this explosion of options for treatment of hormone-sensitive prostate cancer as well as castrate-resistant prostate cancer without metastases. So there's a lot to cover today, and I'll go through kind of the data that we've seen recently. So to start off, we're going to talk about kidney cancer and really first-line treatment, which has dramatically changed in the last couple of years, and now again dramatically changed in the last 6 months or so. And so this is really the big study to talk about. It's called Keynote 426, and it is a newly diagnosed kidney cancer trial, first-line treatment, no previous treatment, for patients with all risk, patients of all risk groups. They were essentially randomized 1-to-1 to sunitinib, which was our old standard of care, given per FDA-approved dosing 4 weeks on, 2 weeks off, versus this new combination of pembrolizumab, which is an anti-PD-1 immune checkpoint inhibitor, given every 3 weeks through an IV, in combination with axitinib, 5 milligrams twice daily, which is another VEGF TKI, but thought to be a little bit more tolerable in combination with some of the checkpoint inhibitors than sunitinib. This was originally presented in February, and the updated data was presented at ASCO this year in June. And this is really the bottom line of the trial, which shows a benefit in overall survival for patients treated with the combination of pembrolizumab and axitinib compared with sunitinib. And the hazard ratio for this benefit is 0.53. So there's a real benefit here. You can see very statistically significant. These survival curves separate early and stay separate, with that green line on top being the combination treatment. And you can see, a more than 10% difference in 12-month survival for patients that were treated with both agents. And so very quickly, this became a standard of care for patients. It is FDA approved now, and we are standardly using it for many patients. The other sort of secondary outcomes to show out of this trial, so the progression-free survival similarly had a benefit. Something we don't always see with immunotherapy trials, but we do hear probably both because immunotherapy is useful, but also because it's given with an oral agent that has a good effect on progression-free survival. The response rate overall was about was almost 60% for all comers. And you can see a benefit across subgroups, which is really important, I think, as you look at all the data. And so this is the favorable risk patients. So these are patients that have good risk disease, not a large number of risk factors for poor prognosis. And you can see the hazard ratio sticks. It's 0.64 in this subgroup. It's not significant, but that's really only because we don't see the events yet. Not that many patients have died in the favorable risk group. So I think the takeaway is not that it's not significant, it's that the hazard ratio is still favoring the combination treatment. And you can see, similarly, it is just as effective in the intermediate and poor risk groups with a good separation of curves. So that's really pembrolizumab plus axitinib is a new standard of care for metastatic kidney cancer. This is kind of the second trial, came out almost at the same time, actually a little bit sooner at ESMO last year. And it is really similar combination. It looks at avelumab plus axitinib and compares it to the same control arm, sunitinib. Avelumab is also an immune checkpoint inhibitor, targets PD-L1. And it has pretty similar results, although they have only become significant so far for progression-free survival and response rate. And so this is just a summary chart. If you look at the two columns on the right, it's the overall population. And you can see that there's a progression-free survival benefit of what goes from 8.4 months with sunitinib to 13.8 with the combination. And similarly, the response rate goes from 26% to 51%. So clearly the combination looks better, but it has not yet hit statistical significance for overall survival. And so it's being used less, I think, across the country / world because of this difference. And so with incorporation of these two studies into metastatic kidney cancer, the question becomes, what is now not a standard of care first-line option for metastatic kidney cancer? So there's ipi-nivo, pembro, axitinib, which is what we just saw, sunitinib, and avelumab plus axitinib.
All right, and take just maybe 10, 15 more seconds, if you would. Again, all anonymous. We're not going to track you down if you get it wrong, but do take your best shot at what the answer is. Dr. Rose, how are they doing?
Actually, so the answer here is now C. So because of these studies, sunitinib has gotten beaten by a couple of the other combination trials, and there was an earlier trial that looked at ipi-nivo that also looked better than sunitinib. And so now I would say any of the combination options are still treatment, and sunitinib is now not standard of care. And so this is kind of a summary of the 3 trials. I only showed you data for 2, but that trial on the right with ipi-nivo, ipilimumab plus nivolumab, which is 2 different checkpoint inhibitors, is called Checkmate 214, and also showed a benefit over sunitinib. It was presented a couple years ago. And so I just kind of highlighted the big differences between these trials. All of them met some of the primary endpoint, but you can see kind of the first and the third, the pembro plus axitinib and the ipi-nivo, both have an overall survival benefit compared to sunitinib. And so those are really the 2 preferred options. And the other thing that I will highlight is the response rates here. So the overall response rates approaches 60% with pembro plus axitinib. It's a little bit less, about 40% with ipi-nivo, but the complete response rate is a little bit higher with ipi-nivo. The other thing that I didn't show is that the ipi-nivo data looks a little bit less favorable for patients with good risk disease, and I just showed you that the pembrolizumab plus axitinib trial looks good for patients with good risk disease. That's the other big differentiation between sort of first-line treatment and kidney cancer right now. And so now I'll talk about the adjuvant data. This is oh, right, there's another question. So what is the best treatment recommendation after resection of oligometastatic disease in kidney cancer? Sunitinib, pazopanib, atezolizumab, and surveillance. Give it a few seconds to see if anyone else wants to weigh in. Okay, good. So actually, based on some recent ASCO data that we saw, the right answer is surveillance. And so I'll show you that data. So this is a study that took patients with oligometastatic disease. So that means metastatic kidney cancer, but only in one site, and it was resectable, or one or a couple sites that were resectable. And so these patients had all of the disease that we knew about cut out, and then they were randomized to either pazopanib, which is a tyrosine kinase inhibitor pill, versus placebo. And this trial was really interesting because it was disease-free survival. You can see there's no difference between placebo and pazopanib, with a non-significant hazard ratio. And then this line is actually overall survival that was blinded. And you can actually see that the placebo arm looks, if anything, a little bit better, although this was also not, this was barely significant. It was right on the line of significance. But this is really strong support for not treating patients with pazopanib after surgery, because we know for a fact that those patients have a lot more side effects than people on placebo. And so really surveillance after resection of oligometastatic disease remains standard of care in kidney cancer. It really was before this study as well, but I think this study really cemented that as the right practice for us. So next I'm going to move on to one agent in bladder cancer. We've seen a lot of movement in the bladder cancer world, and actually a lot more to come, I think, in the next month or so. But this is a really interesting agent that is coming up in development, has really good data behind it, and a lot of excitement. And this is a study, a single-arm study of 128 patients who had already been treated with platinum-based chemotherapy and immunotherapy and received this drug called enfortumab vedotin, which is given 3 out of 4 weeks through an IV. And this is an antibody-drug conjugate. It's kind of similar to brentuximab vedotin, which is used in some of our heme malignancies, except it's called enfortumab, and it actually targets Nectin-4, which is expressed on a lot of bladder cancers, but a lot of other cells in your body too, like skin. And then it is linked to essentially a chemotherapy molecule. It's a microtubule disrupting agent. And so it's thought to target the cancer more directly and deliver this payload of chemotherapy to the bladder cancer. And we've seen some really exciting results with it, and there's actually more to come with it in combination with some of our other treatments. But this is just the plot of all the patients that received this drug on the trial and sort of what their tumors did. And so the patients whose lines drop from 0 down are patients who had shrinkage of their cancers. And you can see most people had some shrinkage of their cancers, 84% of patients. And so that's a really good number for this cohort of bladder cancer patients. These are historically patients with really poor survival. And so this is really exciting. And so I just wanted to show you that because I think we're going to hear a lot more about this drug, potentially with an FDA approval. It already has breakthrough approval. And now I'll go into sort of prostate cancer, where we just have this laundry list of options for treatment and some of the different types of prostate cancer. And so the first disease setting to talk about is hormone-sensitive metastatic prostate cancer. So these are patients that are just getting started on androgen deprivation. For many years, we just gave androgen deprivation. In the last 4 or 5 years, we've learned that some chemotherapy like docetaxel and also abiraterone and prednisone are improved survival in this setting in combination with ADT. And then in the last 6 months at GU, ASCO, and ASCO, we've learned that there's other agents that also can improve outcomes. And so currently, in combination with androgen deprivation therapy, which is not an option for metastatic hormone-sensitive prostate cancer. So docetaxel, enzalutamide, cabazitaxel, abiraterone, prednisone, or apalutamide. Okay, good. So you guys got this one right. That's right. Cabazitaxel is currently not an option for metastatic hormone-sensitive prostate cancer. It's approved for use for castrate-resistant prostate cancer after docetaxel. So there's 2 studies I want to talk about that were presented in the last 6 months in this space. One is called ENZAMET. So this was the ASCO plenary this year, or one of the ASCO plenaries this year, and it looked at patients with metastatic hormone-sensitive prostate cancer, all volumes of disease. They even allowed some patients that got chemo at the same time and randomized them to androgen deprivation plus a standard nonsteroidal anti-androgen, that's something like bicalutamide most commonly, or androgen deprivation plus enzalutamide, which is a later generation anti-androgen. And they compared survival. So this is really the primary endpoint of the trial, looked at overall survival. You know, this is a patient population that tends to live for years these days, and so it looks kind of like a breast cancer curve, which is great for prostate cancer, and shows that, you know, there is an overall survival benefit to enzalutamide compared with a first-generation nonsteroidal anti-androgen. So essentially, adding enzalutamide to androgen deprivation therapy improves survival in hormone-sensitive prostate cancer with a hazard ratio of 0.67. And that's really the big news. It's a new option for treating this disease. And you can see there's also a benefit to progression-free survival, time to PSA rise, time to clinical progression. And so really across all of the endpoints, you see that enzalutamide improves outcomes. Very similarly, we saw results from the Titan trial, which randomized a different drug called apalutamide that essentially works, also an anti-androgen, very similarly to enzalutamide in the same patient population. And so this is essentially very similar inclusion criteria, gave patients either apalutamide or placebo, and we saw very similar results. This is the radiographic progression-free survival. That was better with apalutamide than placebo, and similarly, overall survival was better with apalutamide than placebo. This is not surprising given these are really similar drugs, but apalutamide is also a potential. And so now we have actually this huge chart of what we can use in hormone-sensitive disease. We've never actually compared these to each other, and so we can only sort of put the trials next to each other and say, oh, well, they all look kind of similar and they all improve survival compared to nothing in combination with ADT. But we don't really know for each individual patient which one of these is better. I will point out, if you look at the docetaxel, which is the chemo option, on the left there, and you look at the low volume disease patients, the hazard ratio is not quite as impressive and not as significant. And so we do tend to use docetaxel less commonly in low volume patients and prefer one of the other oral treatments. But other than that, you know, the overall survival hazard ratios look really similar between these four options. And it's hard to pick sometimes. So a lot of the way that we do it is based on patient preference, based on other potential side effects. You know, someone with heart failure might not be a great choice for abiraterone. Someone with poorly controlled diabetes, similarly, because you have to have prednisone with it. Someone with history of seizures, not a great choice for enzalutamide, etc. But really, bottom line is we now have a lot of options to use in this space, and we can really tailor treatment to each individual patient. And the chart for options for castrate-resistant prostate cancer, but without clinical metastases, is growing nearly just as big, and we saw some of this recent data as well. And so there was a trial, this was actually presented at the GU ASCO, but I thought it was important to include to sort of introduce you to a new agent that we're seeing. So it's called the ARAMIS trial, and it looks at darolutamide, which again is just another androgen receptor inhibitor, anti-androgen, but it's a little bit distinct than enzalutamide and apalutamide, and it's thought to have less CNS toxicity. We see a lot of sort of fatigue with enza and apalutamide, and this is thought to not cross the blood-brain barrier as much. It has fewer drug interactions, and so there's some thought that maybe this will be better tolerated in some of our patients. And so, so this is a trial where patients were given either darolutamide or placebo, and so this is a space that standardly didn't get that wasn't treated. That placebo was an ethical choice up until the last year or so. And the primary endpoint is metastases-free survival. So these are patients without known clinical metastases, and really the endpoint is development of them. And this is approved by the FDA as sort of a nice surrogate endpoint in prostate cancer in this space. And so patients with non-metastatic castrate-resistant prostate cancer were randomized to either darolutamide or placebo. I will point out that the PSA doubling time is really important in these patients. All of the trials that have looked at this space have included patients with PSA doubling times of less than or equal to 10 months. And so these patients who have doubling times of like 2 or 3 years that have been just cruising along, those are not the patients we're thinking about, and then maybe they don't need treatment. This is really a higher risk population. And you can see that metastasis-free survival improves with darolutamide compared with placebo with a really significant hazard ratio. Similarly, overall survival looks better, and it just reached significance in this trial, and PSA progression clearly looks better as well. And so now I put up the chart of sort of what to use in non-metastatic castrate-resistant prostate cancer, which is also growing. And so this trial I just showed you is called Aramis on the right, but now we also have apalutamide and enzalutamide. And you can see all of these trials actually look really similar. If you look at the overall survival row kind of in the middle there, all the hazard ratios are pretty similar. Aramis happens to meet significance, but it's likely just a power and event thing at this point, my guess. And you can see that, their primary endpoint, metastasis-free survival, is really better across trials. And so we can use any of these for this cohort of patients that has non-metastatic castrate-resistant prostate cancer. And so, that's really the big data. I think, we saw a change in standard of care options for first-line kidney cancer. We confirmed that you should use surveillance for patients who have an oligometastatic disease resection in kidney cancer. This really exciting new drug called enfortumab vedotin in bladder cancer. We saw the laundry list of options for hormone-sensitive prostate cancer, and now this list of options here for non-metastatic castrate-resistant prostate cancer. And so I think, all of GU cancers are really having exciting times with all these new ways to treat it. And so I think now we can maybe turn over to lung cancer and learn something more about what's developed in lung cancer in the last year. So let me give you this
All right.
keyboard here.
Thanks. All right, so let's talk about lung cancer. So Keynote 42 is a study that compared standard of care chemotherapy to single agent pembrolizumab for stage 4 or metastatic lung cancer. With a PD-L1 that was at least positive. And critically, for looking at the survival data here, crossover was not allowed, and de facto crossover to other options was fairly rare. Here's what happened. In the overall study, we see that pembrolizumab beat chemotherapy with a hazard ratio of 0.81 for a PD-L1 positive population. But prior to seeing the Keynote 42 data, we already had a hint that for the 50% or higher population that this was a treatment option, and that was confirmed here. If you look at the top curve, for patients with a high PD-L1 or PD-L1 by the TPS method of at least 50%, this is confirmed with a hazard ratio of 0.69. But perhaps the clinical question most on many of our minds was, what should we do with our PDL1 lower population, the 1 to 49% population? And here you see that the pembrolizumab failed to beat chemotherapy, no statistically significant difference. And we'll come back to this later, but a crossover between the curves suggesting that there might be two distinct populations that we're not identifying by PDL1 here. And so in my clinical practice, I will consider single agent pembrolizumab only for patients who are either not candidates for a cytotoxic doublet or who decline it. And that's because of data on triplets that we'll get to very shortly. Here is that data. Keynote 407 was a squamous metastatic or stage 4 trial. There was a similar trial, Keynote 189, for non-squamous patients. I'm not going to take up your time going over the data on both because it's nearly identical. So we're looking here at carboplatin plus dealer's choice of taxane. It can be paclitaxel or nanoalbumin-bound paclitaxel, either alone or with the addition of pembrolizumab. Interestingly, pembrolizumab was continued as maintenance, and importantly for the forbidden but commonly performed cross-trial comparison, when looking at survival, crossover was specifically allowed on this study. Here are the results. we see a clinically meaningful and statistically significant improvement in progression-free survival with a hazard ratio of 0.56. And for survival, again, clinically meaningful and statistically significant at 0.64. Here's the data broken down by PD-L1 status. For patients who are TPS, PD-L1 positive but mid-range, we see here a clear advantage, and this is the population that we're probably most commonly seeing in practice. Interestingly, for the PD-L1 negative patients, still a very real treatment advantage. And as you might expect, for the most selected patients, still a treatment advantage. Nothing wrong with using triplet for PD-L1 50% or higher, either in all patients or for select patients with bulky aggressive disease. In my practice, I heavily favor pembrolizumab alone for these patients for toxicity and human concerns. Of course, if you're adding pembrolizumab to chemotherapy, a key question here is, okay, there was that survival advantage. What cost did it come at? The toxicity addition was really additive, and I would say very acceptable for that impressive improvement in survival. Of course, toxicity isn't all of what we care about. What we really care about is quality of life, and global quality of life actually trended favorably for the addition of pembrolizumab. And the common sense explanation is that lung is a brutal cancer, and a more effective cancer, even if it does have some more toxicity, can prevent enough disease-related suffering to outweigh the additional toxicity of the treatment. So I apologize for the messiness of this data, but it's or the lack of prettiness of the slides, but it's brand new, and I have to share it with you because it's so inspirational. What you're looking at here are lung cancer patients treated on pembrolizumab's phase 1 study. And in the overall results, what we're seeing here is that in previously treated patients, we have a 15.5% 5-year overall survival. This is the lung cancer we're talking about. And perhaps more applicable for modern use, where pembrolizumab is mostly used in frontline, 23.2% 5-year survival. Now, again, we're not using single-agent pembrolizumab that much for frontline, except in our PD-L1 high population. Where does that look like? 30% 5-year survival. So I think we can also make our comparisons to breast cancer and feel like we're making some good advantages here. So you saw in the triplet data that PD-L1 was a lousy biomarker, right? In our PD-L1 negative population, we still had benefit from the addition of pembrolizumab to a platinum-based doublet. In other words, it has poor negative predictive value. It doesn't tell you who not to treat. We've started to have biomarkers that actually do have decent negative predictive value. The first we saw were EGFR and ALK. And now RED actually has some data too. Patients with these actionable molecular changes have very, very low rate of response to immunotherapy. And so immunotherapy can either be avoided or reserved for very late lines for these patients. SDK11 newly joins this group. It is most frequently seen as a co-occurring mutation with KRAS, but can be seen alone. Its other name is LKB1. And what we saw a few years ago, summarized here with apologies for the busy slide, was that for single-agent therapy, this did not seem like an effective thing to use PD-1 inhibitory therapy for patients with LKB1. And so what many of us did was quietly shift our practice to give only triplet therapy to these patients, with the idea that if it doesn't work, you have the chemotherapy there to rescue you. If it does work, you don't want to deny patients their benefit. What we saw at ASCO this year was that comparing triplet with immunotherapy to cytotoxic doublet alone, there did not seem to be any advantage for the addition of the immunotherapy. And so this remains a little bit controversial, in my opinion, because we're so attached to the inspirational gains that some patients are getting with PD-1. But I actually have changed my practice to not use triplets in patients with LKB1 and to instead use cytotoxic doublets alone, or in the case of non-squamous disease, perhaps with the addition of bevacizumab. What can we offer patients with actionable mutations? I mentioned earlier the failure of immunotherapy efficacy in patients with RET gene rearrangement, but that's okay. We have targeted therapy. You're probably familiar with the targeted therapy story in lung cancer and other cancers. If you match target with targeted therapy like a lock and key model, we typically see roughly 2/3 response rates with durability that exceeds that of chemotherapy, toxicity that is superior to chemotherapy, and of course improved patient convenience. Blue 667 is a highly selective RET inhibitor, shown in bottom left with the kinome profile. There is another agent from Loxo that is perhaps even slightly more specific, and that explains the toxicity results you're seeing at bottom right. A very acceptable toxicity profile and favorable to that we expect with chemotherapy. And of course, a beautiful waterfall plot above, the kind of shape that we expect with true targeted therapy. As RET accounts for about 4% of adenocarcinoma of the lung, this is a substantial population that will now have access to targeted therapy. KRAS, of course, our first oncotarget in lung cancer, discovered about the dawn of the internet and has perhaps more failed trials than any other agents. This is 25% of adenocarcinoma of the lung is driven by KRAS. There are multiple KRAS isoforms. Here we're talking about KRAS G12C, which is about half, or roughly 13% overall of lung cancer. Importantly, KRAS G12C is also present in other cancers, including colorectal cancer, appendiceal cancer, and others. AMG 510 is a small molecule tyrosine kinase inhibitor of KRAS G12C. You can see at bottom left that its toxicity profile was very acceptable, very consistent with what we expect for targeted therapy. And the waterfall plot with a very small number of patients showing responses. 5 out of 10 here. I would note that if you look at the color coding, the patients without response were at lower dose levels, and as we often see on phase 1 trials, we can hope, and I believe expect, that as more patients are treated at dose, that response rate will creep upward from the 50% shown here. EGFR is usually a mutation we speak about with hope. The classical changes in exon 19 and 21 started the targeted therapy story in lung cancer. In contrast, exon 20 insertions are associated with de novo resistance to first-generation EGFR inhibitors like erlotinib and gefitinib. What you're looking at here is TAK788, a specific inhibitor of exon 20 of EGFR and also exon 20 of HER2. Toxicity shown at bottom, some diarrhea here, as we expect with many of our TKIs, but a profile that I would argue to be superior to that expected with most chemotherapeutic agents. And here is the waterfall plot. Depending on which change you're looking at, roughly a 50% response rate with efficacy across the exon 20 insertions. So MET-DEL14, MET has also been, like KRAS, has been a historic graveyard for clinical trials. Perhaps the first evidence of success was with crizotinib. Data from ASCO, gosh, I think 2 years ago now, that I would summarize for you as not as impressive as we would like with targeted therapy, but consistent with activity. What we have newly are 3 new agents, capmatinib, savolitinib, and tepotinib, that have much lower IC50s, more consistent with what we expect with true targeted therapy. And as well, we're defining what it is to have MET in a more modern way, in this case, MET-DEL14. Here's the data we saw on capmatinib, both in pretreated patients at left and frontline patients at right. Beautiful waterfall plots consistent with true targeted therapy. In pretreated patients, a PFS of 5 months, rising to 10 months in frontline patients. I would argue meeting the bar for targeted therapy, but also leaving some room for improvement. Here's the toxicity. There are some real toxicities, including edema here, but again, a profile favorable compared to chemotherapy. And finally, we come back to a target that you probably already know, ROS1. This is a target that has some molecular similarity to EML4 ALK. As you know, crizotinib is FDA approved for EML4 ALK and ROS1, had our first positive data in MET-DEL14. But as you can see in the table at bottom, like its activity against MET-DEL14, the IC50 against ROS1 is a bit higher than we'd like. And we now have new agents with much higher specificity. One example of that is repotrectinib, and we saw data on it. At left, you're looking at data in the frontline patients, at right in pretreated patients, impressive, beautiful waterfall plots. And I would point out that as we have an emerging expectation of intracranial activity from our targeted therapies, REPO does meet that bar. I thank you for your kind attention and end my talk as I end just about all my talks with a cute kid's picture slide.
All right, Dr. Weiss and Dr. Rose, thank you both so much. So let's see, if you could pass the keyboard back to me, that would be great. Thank you. So now a brief thank you, and then we get to the Q&A portion of our presentation. I do want to thank the generous support of the North Carolina General Assembly for their funding of University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center. We want to acknowledge Mary King, Veneranda Obore, and John Powell for all the hard work they do for this and every one of our lectures. And open it up to questions, and you can use Poll Everywhere. We do have, and we're ending. We're not ending, but we're done with the presentation just a little early. And we do need to make sure that we go for approximately 8 more minutes so that everybody gets credit. So it's really on you to, as our audience, to ask those questions. So Dr. Weiss, what assay testing do you use for the SDK11?
So the first thing I'll say, to be clear, I think I said it before, is that this is an emerging piece of data, and there is not expert consensus on what to do with SDK11. I've shared with you my opinions. So to me, this comes to the broader question of how to best do molecular testing in general for non-squamous, non-small cell lung cancer. In my opinion, every non-squamous patient of stage 4 should have comprehensive molecular testing. In my opinion, next-generation sequencing is the best way to do this for 2 reasons. First, slightly greater sensitivity for the classical changes like EGFR, ALK, ROS1 that we have known, loved, and action for years, but also for the breadth of testing. With a good next-generation panel, you get pretty much everything that is actionable either by standard of care, by an easily available off-label target, or on clinical trials. And the modern reports really give you a nice summary of the level of evidence and how to use these. So my answer is next generation sequencing. Now, the obvious follow-up question would be, what about your squamous patients? I'm not aware of this change being common in squamous lung cancer. Of course, we're not looking that often for it. So it's really my non-squamous patients that I'm testing. To drill down further to a question you might ask, well, how are you getting that? In my practice, I mostly use Strata that we have available on clinical trial, and have been pretty satisfied with that. For those looking for a widely available commercial option, I think Foundation Medicine is most commonly used in the United States and does a very nice job, and have no conflict of interest with them of any kind.
Great. Thank you, Dr. Weiss. Dr. Rose, is the PROSPER trial still recruiting patients?
So I assume that you're talking about the kidney cancer trial, which the answer is yes. There's actually a PROSPER prostate trial that is completed or accrual. But to answer the kidney cancer trial, so now that we have all this wonderful data of first-line immunotherapy in combination with another immunotherapy or another TKI, we are now moving treatment earlier. And so the PROSPER trial in kidney cancer is a randomized trial looking at perioperative nivolumab, which is an anti-PD-1, versus standard of care nephrectomy for high-risk localized kidney cancer. It's a really great trial because it gives nivolumab both pre-op and adjuvantly, which is a lot different, or a little bit different at least, than a lot of the other immunotherapy trials that are pure adjuvant trials. And so, yes, it is very much still recruiting patients. So eligibility is T2, so 7 centimeter or greater localized renal mass. It's actually, because nivolumab has such a long half-life, we have it open here at UNC. We've had really good success, actually not even delaying surgery for patients for nephrectomy, because we can typically screen quickly. And so you get randomized to either treatment with nivolumab, which is 1 dose pre-op and 9 doses after, versus observation. So it's not placebo-controlled, which is really nice for our patients too. It does require biopsy if you get randomized to the treatment arm, but we're very much still recruiting nationally, and I think recruitment is steady, but there's lots of room to put more patients on and give them this opportunity to cure more kidney cancers.
Great. Who should one contact for more information about that?
You can contact me. If you go to the clinicaltrials.gov, I think it'll give our the clinical protocol office at UNC Great. As well. But
great. And if you email us at unccn@unc.edu, we'll be happy to forward on any correspondence. All right. What advances have been made to predict those who have prostate cancer will still progress to Mets disease?
Yeah, I think this field is developing rapidly. I think a little bit of the answer to sort of whether we're talking about localized prostate cancer that will recur with metastatic disease, or whether we're talking about sort of the population I talked about in the talk, which is patients with a biochemical recurrence but don't have clinical metastatic disease, which actually, as our imaging is getting better, is becoming sort of a smaller population. There's a lot of both genomic sequencing and really RNA sequencing looking at trying to predict these patients. I think, the clinical most useful factors that we look at is clearly, Gleason score, staging, all of the standard things. I think for the M0 patients who have either biochemical recurrence or castrate resistance, really PSA doubling time is very predictive of progression to metastatic disease. I think from the earlier stage prostate cancer, there's a bunch of sort of clinical tools that you can use to help predict metastatic disease. But I think the bottom line is that we are still working on sort of RNA, our understanding of gene expression and genomics and how that can play into progression to metastatic disease.
All right. Thank you. And Dr. Weiss, do you advocate both tissue and liquid plasma testing of all NSCLC patients?
Yes and no. Mm-hmm. The no is mostly because it can be difficult to get that paid for, and sequencing is very expensive. Mm-hmm. You don't want your patient getting a $5,000 bill unless there's appropriate counseling and it's very necessary. Mm-hmm. There are advantages to both tissue and liquid testing. The advantage of traditional tissue is that it is more sensitive, so you will have a proportion of patients with metastatic disease you try to do liquid or blood-based testing on, in whom that testing fails. That these in particular patients without extrathoracic metastasis, you're less likely to pick up an actionable change if it's present. On the other hand, there are many advantages of the liquid testing. In some settings, it can be hard to acquire adequate tissue. Tissue can be used up due to either a limited sample, due to poor tissue stewardship, and by that I mean doing 30 IHCs to prove it's lung cancer when it's clearly in the lung, or accessibility issues. And liquid overcomes that. Liquid is also faster. It's the biggest advantage we see here at UNC is that while it can take several weeks for a tissue-based next-gen result to come back, you can get your blood back in about a week. And so I do think that there are complementary roles for using liquid and tissue testing. One strategy is to send off the liquid while you're arranging the while you're sending off the biopsy and cancel the tissue. If the liquid comes back useful, if you have your tissue-based assay on a study, like we have, for example, on Strata, my patient isn't faced with that, the potential large bill for testing twice. I can send off the Strata for free. I send off the liquid for speed, and if they both give me the same information, nobody's harmed in the process. So I do think that these are very complementary in what they have to offer our patients, but in routine standard of care clinical practice, I think that the finance issue gets in the way of testing for both, unless you're very clever about how you do this.
Gotcha.
I see we don't have another question, but maybe I can ask one.
Yeah.
So I'm kind of curious. So when I was a resident, I did a whole lot of moonlighting on a high-dose IL-2 and biochemo service that was filled with wards of renal cell patients. And given how many nights of my life this was, I'm kind of curious, is IL-2 a part of renal cell, metastatic renal cell care? Is that a thing, or did that kind of die with newer agents?
So it is still a thing in very select patients, but we are having a lot of trouble figuring out who exactly those patients should be these days. If you look at the long-term complete response rates of high-dose IL-2, they are not as good as some of our, or not any better than like Ipi/Nivo, for example. And clearly high-dose IL-2 is more toxic and hard to tolerate.
I'll never forget that.
And is, only available to a select group of people with not very many comorbidities. And so it is a rare patient these days that actually get high-dose IL-2. For a little while we had the Ipi/Nivo data that showed a benefit in intermediate and poor risk patients, but not so much benefit in good risk patients, we were sending a lot of good risk patients for consideration of high-dose IL-2 because those patients still looked like they had benefit from high-dose IL-2 like the other risk groups. But now that we have this new pembrolizumab data that looks so strong with some complete responses, it's hard to it's hard to give high-dose IL-2 to too many people. The response rates being 60+% for pembrolizumab means that the majority of people should get that instead of high-dose IL-2. If we could figure out who that 5 to 10% are that are going to have the long-term response, it still may be worth it in those patients. But we also don't know if they're the same ones as those that have CRs to Ipi/Nivo.
That which seems like the perfect segue to the next question, which was, are there other genomic markers on the horizon for either, start maybe with GU, or lung cancers that look promising for treatment targeting?
Yeah, I think a lot of this is going on in bladder cancer these days for GU. I think we just had the FDA approval of erdafitinib, which is now approved. The data was actually before ASCO, so I didn't present it, but it is approved for FGFR-altered patients now in bladder cancer. That has, a lot of beautiful targeted therapy waterfall plots like we just saw for lung cancer. And I think there are many, many ongoing targeted treatment trials in all of our cancers, although mostly in bladder cancer, I think, that are looking at a bunch of different agents. Just at UNC, we have a trial open looking at homologous recombination deficiency tumors using olaparib in bladder cancer. We're looking at ERB mutations using afatinib in bladder cancer. We have another FGFR inhibitor trial open. We have several trials of prostate cancer looking at some of the DNA repair defects in prostate cancer, which we're learning are more prevalent than we realized that they were. I think kidney cancer is a little bit behind on this compared to the other GU cancers, but I think there's lots exploding in all of our cancers.
So in lung cancer, it feels like every year we have a new target. The story, started off more than a decade ago with EGFR, which represents 15% of our disease, of our adenocarcinoma patients. And then we got ALK gene rearrangements at 4%. Then we got ROS1 at 2%. Our newest approval that is applicable not only for lung cancer, but is found across human cancers is NTRK. NTRK 1 and 2 are found across human cancers, and it was an interesting approval, or approvals now, in that the drugs were approved agnostic to tumor type, just if you have the molecular change. And then, you look at RET at 4%, MET-DEL14 I showed you, roughly another 4%. And so, it's almost obligatory in these talks when you talk about molecular therapy in lung cancer to present the data as a pie chart. And what I've noticed in this obligatory pie charts is that every year the other/unknown portion of the chart keeps shrinking away. So I think we can expect that trend to continue. A difficulty for those of you who are trying to treat not just the most important cancer, which is to say lung cancer, but also less important cancers like bladder and renal and such, is that there's a proliferation of rare targets here, right? We're getting more and more of these 0.5%. 0.75%. These are challenging to study, and I imagine challenging to keep track of if all of your practice isn't in that narrow blinder range of lung cancer. And so that's where hopefully education events like this can be helpful, quality reference materials, and I would say some of the onus on those who write these molecular reports to make this easy for all of us to get right, to quickly find the appropriate data.
Great. Dr. Weiss, Dr. Rose, thank you both for your very thoughtful answers. Thank you to our audience. We love our UNC Cancer Network audience, and thank you for all the thoughtful questions. We do have more lectures coming up, always. September 11th, Professional Development and Continuing Education for Oncology Nurses with Claire Gillette. September 25th, Cardiotoxicity and New Therapies with Dr. Brian Jensen. So we hope you'll be here for both of those. We have more self-paced lectures. We're always adding to our self-paced lectures and helping patients with breast cancer and decision-making in metastatic breast cancer. The first with Catherine Harrell, the second with Dr. Lisa Carey. Those are both available, as are Radiation Oncology 101 and with Jane Kempereel and Mary Fleming Knowles. That's available, and Improving Outcomes in Radical Cystectomy with Dr. Raj Pruthi. So lots of new lectures. You can take those from when they're released anytime within a year. They're all free. Please spread the word about both the live lectures and the lectures in our portal. Cancer Conversations, no credit here, but this is our series for the public. This Friday, Get Started with Exercise with DJ Amatuli, and he's from the Get Real and Heal program. And then next, last Friday of September, Prostate Cancer Screening, Does It Save Lives with Mary Dunn. So we hope you'll be here for both of those. Thank you for participating. Questions, comments, unccn@unc.edu. Find us on our website, unccn.org. This will be recorded in our portal soon. Any questions, information about upcoming lectures as well. So thank you all. We really appreciate you being here. We'll see you next time. Dr. Weiss, thank you so much. Really appreciate it. Dr. Rose, thank you so much.
Thank you.